It's the MMA. Well, sure, I'll go to the other side. Are we getting one other? Okay.
Yes,
Yeah.
yeah, right there.
I think you're, sure, well, just for now. Even though it's super helpful for me, so then I know who you are and I can ID all of you.
Yes, Sandra, I'm off.
Test 1, 2.
Alright. Closer together,
Okay.
please. Go, right up here. Perfect. One more. Folks with glasses are not tall, down a tiny bit. Again. Perfect.
Thank you.
Thank you very much.
Oh, you're not late.
Okay, and then I'll just get. And then go to groups. Yeah. Oh, he's engineering student. So we have a guy.
booth at the medical society, etc. It's the only one where the money flows the opposite way. And that was an opportunity. So I said, I'm going to take on a multi-billion dollar set of businesses. And I pulled the 990s, which are the nonprofit tax forms. And I looked at how much money they had. And I can tell you, this is a multi-billion dollar collection of businesses. And I decided to blow the whistle on them basically and say, you've got to start treating our people more equitably. And part of the reason is because I was telling all these women to spend money, leave their families, leave their kids, leave their patients, go to the medical societies, present. And if they did that, what would happen? They'd get promoted all the way up the top. But wait, they weren't getting promoted all the way up the top. So what I was saying was not consistent with the data. And there's no way I was going to tell women something that wasn't true. So I said, I'm going to tell them the truth, and I'm going to break open some doors, smash some glass ceilings, etc. Now, in this study, in PM&R, over the most recent 4 years, zero women had gotten, women physicians had gotten recognition awards. Now, imagine sitting in an audience of thousands of people, and we're only clapping for the men who are getting awards. That's a problem. So there was this concept called inexorable zero. And inexorable zero is really interesting. It's used in the US courts and the Supreme Court too. And it basically has a prima facie and on its face inference of discrimination when there's a zero or near zero number. And it flips the burden of proof. So we can assume there's discrimination if we see a zero or near zero number. Now, just because we find a disparity does not mean that we know causality. Causality is known to be multifactorial. So in this study, what happened is for the mid-career women, there were zero nominations. No one nominated any mid-career women at all. Men didn't nominate them. Women didn't nominate them. No one nominated them. For the early career, there were a number of really good nominations. I happened to write one of them, and it was outstanding for a phenomenal person who runs the largest clinical trial in one of the neurologic conditions. She's in PM&R in the country. Amazing. Did not get the award. So after I started looking at this, some things changed. But I didn't want people to just blame PM&R and say, that's specialty. They just don't treat their women well, do they? Because I decided I was going to just look for the inexorable zeros and start pointing out that we have a problem in PM&R, but so do you in your other specialties. So this is a study that's had a lot of citations, a lot of people refer to it, et cetera. And it just shows a lot of inexorable zeros. And so guess what? I think that's sort of a truism, you know? I mean, you can find people, whether it's at the University of Buffalo, whether it's at, UCLA, whether it's at Harvard, there's more than one woman, right? Or there's more than zero women. There's at least one woman. So let's switch and think about strategies for leaders in academic medicine that they can enhance to that they can focus on to enhance gender equity. And what we did in this paper is we said, okay, I just showed you a bunch of problems. Now, what are some solutions? And some solutions happen to be looking at data, analyzing it, and then driving change, just like you would with patient safety and things like that, right? On an ongoing basis, you look at some data, and this is at the department or the division level that can be done. And we wrote a paper on this. And it involves a number of things, and I don't have time to go into it. I could spend a lot of time talking about gender equity and disparities and things, but these are some of the things to be thinking about. Another tipping point was clinical practice guidelines. So I just told you recognition awards research, right? Another tipping point was clinical practice guidelines. And what happened is this study was published in The Lancet, and it showed that women were underrepresented, and even more so, women physicians were underrepresented in clinical practice guidelines. Now, this is a really important study and pretty new, about 5 years ago, 6 years ago, the study came out. And then another study came out and they looked at racialized, what they called racialized people. So they made it binary, non-racialized versus racialized. And again, this is language that was used in the study, and it was language that was published in Lancet, which is racialized is a term that's often used in the science literature. And when you think about this, these are right there, those are white women, non-racialized women, and those are racialized women. So we're not including, equitably including women in general. And we're certainly not including racialized women or BIPOC women or whatever term you prefer to use. Interestingly, this is a study that I did with colleagues, and this is in neurology guidelines. And it's not, it's not all the same, even among the same specialty. Keep in mind that clinical practice guidelines are usually brought together by medical societies, and then they're published in the medical society's journal. So there's, again, these relationships with medical societies and journals, 2 of the 4 gatekeepers I mentioned. And it can vary even within subspecialties, how women are included. So I started talking about this, and this is what I heard. Dr. Silver, it's not our fault that they didn't invite women, that they didn't invite BIPOC individuals. It's not our fault. And so there was this idea that organizations had to fix themselves, and that they weren't complicit if they worked with an organization that was not treating people fairly. And I thought about that and I said, you know what? There's this thing called fair trade. And fair trade is a social movement. And in that social movement, what we've said for fair trade is we've said that buyers are not going to support growers or sellers who have forced labor, child labor, etc., right? That they're not going to support them. So I thought, I had this idea. The journal Cell, which is a high impact biomedical journal, came to me and said, Dr. Silver, you're one of the leading experts in gender equity. We want to move the bar. What can you do? And I said, there's this thing that I'm thinking about, and I'm going to give it a name. It's called interorganizational structural discrimination. And I'm going to give it 3 criteria, basically. And I'm going to say that organizations that have known problems with structural sexism or racism or whatever, that if you work with those organizations and they have fixable problems that are known to be fixable, that you're complicit in that problem, and that's interorganizational structural discrimination. So let me tell you how it works. So this is a new thing, and it's something that I worked on with colleagues. But what happens is you have a clinical practice guideline, and you have lots and lots and lots of men and hardly any women on this clinical practice guideline, right? And now 10 societies basically endorse it, 10. And they say, oh, it's not actually an endorsement. Yes, it is an endorsement. Your name is on it. Of course, it's an endorsement. And these are going to be distributed throughout the United States and throughout the world. And it's going to drive millions or billions of dollars towards certain people and towards certain things, and away from certain people and away from certain things. That is a problem. So here is the practice guideline, and these are all the organizations that endorse this. And I basically, with my colleagues, said, look, all these medical societies that agreed to put their name on this, that they were complicit, and that is interorganizational structural discrimination. So now I'm not only holding the organization that is, is not treating people fairly, responsible. I'm also saying, if you know they're not treating people fairly and you agree to support them anyway, you're complicit too. So let's switch gears. That was disparities and gender equity and driving that. Let's talk about retention, because I want all of you to stay in medicine and science and all of your fields. I want you to stay. Patients need you. Science needs you. I want you all to stay. So I looked at Harvard Medical School and attrition at Harvard Medical School among our faculty, and there were 3 key findings. The first one was that there was a stickiness factor. If you got people to stay a year or 2, they seemed to be able, they seemed to want to stay more. And so they were significantly more likely to stay, the longer you kept them, basically. Second thing was that all of the race and ethnicity minority groups were significantly more likely to leave, which tells me, boy, number one, on the first part, we need to do better onboarding. And number two, we have got to do a much better job at supporting BIPOC individuals. And number three, women were not more likely to leave in the middle of their careers, but they were at the beginning and also when they were more senior, which again, is probably multifactorial. The middle part may be that they had kids and didn't want to leave, or that they had fewer opportunities to leave and do something really, leadership opportunities. So that brings me to reasons for attrition. Now, interestingly, the EU, physician retention and nursing retention and all that, this is at a crisis level, not only in the United States, but also in Europe, et cetera. The EU has something called the Meteor Project. They're on top of this. I'm not saying it's perfect, but I think the EU is a little ahead of us in terms of really paying attention to this issue. When you look at the literature, there's some recent systematic reviews that have pulled the literature together. And what they've done is they've looked at push and pull factors. Keep in mind, people always get this confused. Push factors and pull factors lead to attrition. They both lead to attrition. They both make people leave their institution, both of them. So push factor would be like discrimination, and a pull factor would be, hey, I've got a great job for you. I'm going to give you a promotion and a lot of money. That would be a pull factor. So we have to start thinking about stay factors. We've got to decrease the reasons that people are pushed away, and we've got to make our opportunities so that people, they're not pulled away by our competition. So one of the things that we've done in our department is stay interviews. And this is actually a best practices business opportunity where you start to say, we want you to stay. And even when we announced that we wanted people to stay, our entire department was like, you want us to stay? That's so awesome. They were so excited. So yes, we want you to stay. Mentorship is another one. This report came out in 2019. It sort of got lost in the pandemic. NASM put this out, and it's super interesting report, worth reading. I like to read these reports cover to cover because I learn a lot and then I can really speak on them. This one in particular, I want to talk about supporting different mentorship structures. And that was such a great presentation that was given earlier. That's exactly what we need, spot on. So this is something that I do, and I just decided we've started to do a lot of speed mentoring. So this is my speed mentoring. By the way, I made these images, pointing and all that stuff with AI. It took me about 30 seconds to a minute to make these images with AI. Really fun to do. And I often teach people during a lecture how to do it. But here's my 30-minute talk with somebody, right? They're a new faculty, let's say. I'm going to tell you the value proposition of our department. Welcome to Harvard Medical School, the Department of PM&R. We do this, this, and this. So happy to have you here. It's great. Next 5 minutes. What are your goals? Tell me what you want to get done in the next 2 to 3 years. Not what do you want to do, 50 years from now or 30 years from now, but what do you want to do in the next couple years? Then whatever you tell me, I'm going to figure out how to connect you because I know a lot of people and I know how to make connections, and I know how to help you get networked to figure out what leadership courses or grants or all these different things. And I'm going to spend 5 minutes on that. Then I'm going to actually take you on the website for faculty promotion, et cetera. And I'm going to show you the tracks, and I'm going to show you how promotion works. I'm going to talk about bibliometrics in the next 5 minutes. Bibliometrics are the data-driven numbers about the impact of your work. Now, Harvard likes bibliometrics a lot. Not all schools use bibliometrics as strongly as Harvard does, but most schools use bibliometrics. That could be citations, H-indices or H-index. Harvard likes to use RCR and iCite, which is an NIH site. Then I'm going to talk about belonging. And here's what I'm going to say. You belong here. I know that this can be a pretty intimidating place at times, but we hired you. We want you here, and you belong here. You are no imposter. You are the real deal. And I will say that no matter where I go, because that's the truth. That is the truth. Now, I use the language of belonging. Let's talk about the language of belonging. What if we had something, let's say, a romantic relationship and the word love was never used, never. You said, you're really great. I think you're awesome. You're wonderful. We're good together. And the word love was never used. I use the words of belonging, including belonging, belongingness, etc. I think we have to use the actual words, not just saying you're part of a team. It's great to be here, but you belong. And I make sure that everyone hears that at least once from me, and then hopefully they'll keep hearing it over and over. So 6 practical strategies to mentor and sponsor women. Sponsorship was brought over from the business world. And what happened is they basically said, say someone's name when they're not in the room, etc., advocate for them. Well, guess what? When you need rank promotion, like instructor to assistant professor, etc., you can't just advocate for somebody and say their name when they're not in the room. And so there was actually some harm that happened when this was just brought into academic medicine. It didn't exactly work. And men were complaining that they weren't getting credit for sponsorship because, they're not saying it when people are around. And also, I noticed a lot of women were getting very anxious and thinking, I need sponsorship. Where do I find it? How do I get it? And I asked the medical students that I met with today, how many of them had heard that they need sponsors and need sponsorship? And they almost all raised their hand. And that can be so anxiety provoking if you don't know how to find a sponsor and how to get it. People tell you you really need it, but you don't know how to get it. So I changed the definition for academic medicine, and this is me writing a new definition. And then I put in these different ways to sponsor people. So we'll have our 3, go ahead and come on over there. Yep. 3 people. So we're going to do it live and we're going to show you how sponsorship works. Now, I came up with this idea called a sponsorship party. And I've done it a bunch of different times and we can do it in different ways. But here's what I want you to know. You're going to see a slide from each person. I've worked with them ahead of time and they have to identify their sponsorship asks. This is a really hard thing actually, because people say, I want sponsorship, but I don't even know what I want. I don't even know what to ask for. You're going to see them ask for 3 specific things. And I'm going to ask you, take a picture of their slide so you have their email. And if you have a way to sponsor them, I'm going to ask you to email them and let them know. But even if you don't have a way, I'm going to encourage you to email them and just tell them that they did a great job and that they belong. All right. So we're going to do this and normally we'll have 3 minutes in between. We're going to do it just 3 in a row to make things go a little faster today, but I hope that you take a picture and that you email them. All right. So first up, we have Nitya Murali.
Thank you so much. Hi, everyone. Thank you guys so much for coming out tonight. My name is Nithya Murali. I'm currently a second-year medical student here at Jacobs. A little bit about me. I was born and raised here in Buffalo. I went to UB for undergrad, and I got a degree in biomedical engineering. Outside of studying, I really enjoy volunteering with Buffalo City Mission at the Women and Children's Shelter. I also enjoy running and spending time with my dog and my family. Since starting medical school, I've realized that there's a few aspects of medicine that I really want to contribute to, especially given my interest in obstetrics and gynecology. The first one is community involvement and improvement. I truly believe that every physician needs to understand and improve the community they work in by actively getting involved with them. And I feel really fortunate that my current research allows me to do some of this. I'm currently working at Jericho Road where I'm evaluating the doula services, which are utilized by primarily refugee and immigrants at Jericho Road on Barton Street. My interest in women's health have also pushed me to pursue other research evaluating health outcomes in postmenopausal women, as well as women who use OBGYN services. And so I realized that I will have to continue to be on this journey of exploring more, learning more. And so my first ask is to be able to connect with an OBGYN who can help me learn more about the work-life balance and learn more about a career as a physician. The second ask is to connect with any faculty that would be interested in sending a letter to the editor regarding a current article that was published about diversity in OBGYN residency programs in the Journal of Obstetrics and Gynecology. And the final ask I have for you tonight would be to give a 5-minute presentation about my current research at Jericho Road so that I can gain more exposure and help get more support for our ongoing work. So thank you guys for all coming out tonight, and I really appreciate it. If you want to put down my email, I would also appreciate that, but thank you guys so much.
Awesome. So that was a medical student. There's a Harvard Business Review article titled "Stop Telling Women That They Have Imposter Syndrome." Each one of these women got the talk. You are no imposter. You're going to be nervous. You haven't done this before. That is normal. That is not an imposter. We're not going to pathologize women by calling them imposters.
Thanks. I really needed to hear that right now. So I'm Dr. Melissa Rahill. I just got promoted this past July to Associate Professor of Neurology. Thank you. I'm the Adult Neurology Residency Program Director here at the Jacobs School. I am married to an amazing high school English teacher, and I have 2 kids, 6 and 9, that keep me very busy. And so having just gotten promoted, I've been told that I already have to start thinking about the next step, which of course is Dean Brashear is nodding over here. So yes. So in anticipation of that, I have 3 asks. So my first ask involves invited presentations, because this is one of the criterion for promotion to full professor, is to have invited talks that establish that you have national expertise. So I have already given grand rounds at outside institutions, at neurology departments, and here within UB at other departments, and at national conferences for neurology and headache. But I would love to do more of them, again, in or out of UB. And I love talking about headache medicine and neurology and medical education. I could do that all day long. So my second ask is that, again, for promotion to full professor, you got to have a lot of publications. I do feel like I've led a lot of great projects, but I'm seeking specifically middle authorship projects where I feel like I could really add value to your publication. I am married to an English teacher. And so especially in the topics for medical education, mentorship, headache medicine, women's health, those are some of my passions, and where I don't necessarily have to take the lead on a project, but I can add value to you. My third ask is a little uncomfortable, but Dr. Silver gave me some strength to ask this. But for promotion to full professor, one of the things that they're looking for are recognition awards. And so I've never had a teaching award, and I feel very passionate about teaching. So my third ask is for consideration for a teaching award, a Siegel Award, a resident teaching award, or just any award related to service to the university or the like. So that was very uncomfortable, but thank you for thank you for your consideration.
Hi, everybody. My name is Emily Ciccarelli, and I'm honored to be representing some of the women here, especially within engineering in particular. So for myself, I'm a Buffalo native. I went to UB. I have a double E degree, so that's electrical engineering. I have 4 children. I've got over 18 years in the engineering profession. I've ranged from anywhere from product design all the way to jumping into HR with talent development, and now leading a large department within Moog. So I am currently a senior manager of our actuation team. I've got about 135 and growing. And so this kind of leads into some of my areas of interest. My areas of interest has always been to help people grow, which has always made me feel like an imposter, an outcast, especially with regards to engineering. But it is something as a leader, as a part of my organization, as a part of just leadership in general, something that I like doing and want to continue to do, as well as helping out our company with regards to diversity, equity, and inclusion. and just establishing some really great standards as it comes to the area of engineering for my organization. So this kind of leads into some of the asks that I have of what I'm currently looking for. So what I'm looking for is a senior leader that focuses on strategic development. In a lot of the areas that I'm currently in, they need you to be that forward thinker, and with a person that constantly is a part of execution, taking a step back on what does that forward look, what does it look like, is something that I would love to have somebody kind of give me some guidance on. Secondary to that is creating that area of diversity, equity, inclusion, somebody that has walked through those paces with regards to their organization. What I'm currently seeing now is a lot of women saying, oh, I'm so glad I finally have another woman that's here as a part of our team. And I want to break down that barrier and create a forum for that. So a leader that has walked through those paces as well to have that inclusive environment. The third ask that I have is that creating certain standards as I'm, again, walking through this new large organization, I'm finding areas that need to be recrafted and created. And as a part of that, it takes a lot of influence too as well to create these standards for folks to follow. I've got folks that range from their career of early career all the way to their, ready for retirement. So from that overall range of folks, how they've created those standards and also placed in influenced folks in order to follow through with those standards. So that's a little bit about my asks, and I appreciate, representing engineering.
Wonderful. So you all did a great job. You saw a medical student, so very early career training. You saw a mid-career physician, and then you also saw a mid-career engineer. So you've seen a lot of variation in terms of the asks and who can ask, who can have a sponsorship ask. Anyone can. And the hardest part is really figuring out what to ask for and making sure that it meets what the audience could actually provide potentially. So another sponsorship thing that I wrote about, and I kind of named it. I like to give things a name so I can write about it and talk about it. And this one is called Elevate Her to a Bigger Stage. Now, I'm on a big stage a lot, and I thought about it and I thought, wow, if I invite someone to just take a lot of my talk, people will be upset that they didn't get to hear me more. But if I carve out just a few minutes of my different talks, I can really elevate someone to a much bigger stage. So in this talk, what you're going to hear is Ashley Alex. She's going to talk about migraine headache, and she's going to do it in a way that I trained our researchers to do for this really big event in which we were raising lots of money when we launched a $70 million campaign. And I taught them to do it in this style called Pechakucha. Pechakucha is 20 slides, 20 seconds per slide, 6 minutes and 40 seconds. It's not easy to execute, but it's a lot of fun. And we're all going to just enjoy this and have fun with it. And we're going to tee Dr. Alex up in just a minute for this. That's it. We have to switch slide deck. So give us just a minute. We have to tee her up for this Pechakucha style. And you'll notice on the Pechakucha style that the slides actually have a little bit less writing. They're not as intense, etc. And, it's supposed to be both entertaining, but also enlightening. And I think the topic of migraine is incredibly important.
Thank you. Can I grab the? Oh, sorry. Yes. Thank you so much, Dr. Silver. I am Dr. Ashley Alex. I am a neurologist and specifically a headache specialist. Just a little bit about myself. I have been in Buffalo for so many years. I came here in medical school, and my husband and I fell in love with the city, and we decided to stay. And I see so many neurologists in this room, and it's so amazing. I love it. All right, so I am going to go through a very quick overview of some of the novel therapies that we have in migraine treatment and specifically focus in on some of the challenges that we have to consider in women.
So, migraine is an invisible disease that affects about 39 million Americans. And these are some pictures that I found online that amazingly depict the excruciating pain, the visual disturbances, the inability to think and concentrate that patients often have to deal with on a day to day basis. And it's not readily seen or appreciated by other people. Migraine affects all ages and all genders, but as you can see on this screen, it primarily affects women of working age and childbearing age. And this is so important because uncontrolled migraine can negatively impact a woman's career growth, her finances, her ability to start and maintain relationships, as well as her decision about having children. This is a great slide, and on the slide you can see that female dominant disorders are in orange and male dominant disorders are in blue. And on the top half you can see that headache and migraine are on the left-hand side of the screen, indicating the high socioeconomic burden. But then on the bottom half of the screen you see that it drops all the way over to the right, showing the low NIH funding. So women have had to deal with medications that were made for other conditions, a low efficacy and intolerable side effects for many years. But now we have a number of new therapeutics to offer patients to allow them to lead more productive lives. And so this is amazing. So we're going to talk about that now. The first of these therapies is onabotulinum toxin A, and this is a little bit older. It was FDA approved for chronic migraine back in 2010. And Botox basically blocks pain signals and prevents activation of pain networks. And it's been shown to decrease the overall frequency and severity of attacks by about 50% in many of my patients. It is a quick procedure that is done in the clinic about every 3 months, and it only takes about 20 minutes. It involves about 31 injections in 7 key areas, and the side effects are pretty tolerable. Patients do very well, although rarely muscle weakness can occur. I do tell my patients that it can take 2 to 3 rounds at least to see the maximal benefit of Botox, so that is very important to discuss. Now, most patients do improve during pregnancy, and so we like to take medications off. But for those who continue to suffer, I think Botox is a great option that we have because they're local injections, and there is a lot of accumulating evidence of safety and lack of pregnancy-related outcomes. So definitely an option you want to consider with our pregnant patients. Moving on, we have our CGRP medications. CGRP, or calcitonin gene-related peptide, is a potent vasodilator in the body that is noted to be elevated during migraine attacks. And so these medications oppose the activity of CGRP and the downstream effects. So these 4 medications on the screen are monoclonal antibodies that have been approved for the preventive treatment of migraine. So 3 of these medications you can see are subcutaneous injections that are given monthly, and 1 is an IV infusion given every 3 months, which is great for patients who don't want to take a daily medication. They're pretty well tolerated, though the Aimovig was shown to cause worsening hypertension and constipation, so something I discuss. Moving on, we have the CGRP receptor antagonists. The field calls them GPANTs. And again, CGRP, these medications were approved both for prevention and acute therapy. And again, they block the effects of CGRP, especially when they're during migraine attacks. So there are 2 medications currently approved for the preventive treatment of migraine, atogepant and rimegepant. And compared to a lot of our older therapies like topiramate and propranolol and Depakote, these have a much more favorable side effect profile. Rimegepant is in the middle, and it's unique because it is the only migraine medication that is approved both for preventive treatment but also acute treatment. And so these 3 medications have been great options for my patients who previously couldn't tolerate triptans due to side effects, they just didn't work for them, or because they had contraindications. Zavegepant is the newest one that came out last year, and it's a nasal spray, so great for patients who have sudden onset attacks or people with a lot of nausea and vomiting. The last medication I'll tell you about today is lasmiditan. Lasmiditan is a medication that is similar to triptans in that it is a serotonin agonist. But the special thing about this is that it does not act at the level of the blood vessels, and so it doesn't cause that theoretical vasoconstriction we worry about. So another great option for patients who have a history of TIA, stroke, or heart disease. So a common question that I get from my patients is, do I have to stay on these medications forever? And the truth is, no, not necessarily. Depending on my patient's specific circumstances, I try to get them stable anywhere from 6 months to a year, and then slowly start to wean medications down to the lowest number of medications, the lowest dose of medications. Again, very patient specific. We also have to talk about family planning at every visit, because this is something that all women think about and deal with, especially with these new medications. They are not safe, considered safe. They haven't been studied in pregnancy or lactation. And with the monoclonal antibodies I talked about first, they need to be discontinued 4 to 5 months ahead of time. Finally, what about perimenopause and menopause? So a lot of my patients do notice worsening of their symptoms with perimenopause, and this is important to let them know about. It's due to the hormonal fluctuations, and we can address this with some of the medications we talked about, as well as hormonal interventions. Most of these patients will hopefully stabilize during menopause when their hormones stabilize, although this is not always the case. So I've mentioned a ton of new medications that have come to the market, and honestly, they've made a world of a difference for a lot of patients. I have patients who can now do acrobatics, who can finally garden for the first time ever, and it's so amazing. I see them once a year, and they've never been happier. But I also have a lot of patients who are non-responders, and they're minimally responsive. And so I think it's so important that we have continued research. We have groups like Headache on the Hill. We have more NIH funding that we're getting now to look at new therapeutic targets like the ones on your screen. Finally, I wanted to wrap up by talking about the role of artificial intelligence in migraine and headache medicine. So this is something new, and it is already being looked at in headache medicine in terms of diagnosis in ERs, looking as being treated as a screening tool for comorbid conditions, and even looking for neural markers to identify migraine just based on MRI imaging. Personally, I'm also already using it to help me craft appeal letters when insurance companies reject my medications. So I think this is a great tool. It's not a crutch. It's not the be all end all, but I think it's going to be a great way to help move the field of medicine forward and hopefully bring access to more and more patients that currently don't see a headache specialist. Thank you.
Great job on that. Excellent. So back to our scheduled program. I'm going to bring up my slides, and almost finished, but we're just moving back. The Pecha Kucha style is a lot of fun, and she was on a timer, but she could advance if she wanted to. You probably saw her do that a couple times. When I trained our faculty, the dean at Harvard, he was like, wow, if we could train all of our faculty to present like that, especially at donor meetings and things like that, it would be great. So we raised quite a lot of money and far past our goal. So let's talk about belonging. The need to belong is a fundamental human motivation. And the thing about belonging is that it's been studied for a long, long, long time, decades and decades, almost 100 years, in fact. And a lot of that science lives in the social science literature and the psychology literature, et cetera. And now that we're thinking about it in medicine, there's a lot of things that I'm reading that kind of look like almost as if we invented it, like, oh, hey, we just thought about this thing belonging. So I really like people to go back to what the social scientists, what the psychologists have been thinking about, and really considering the great work that's already been done so that we're aligned with this really important work. And one of the things that's important about this is that it's your individual perception, your individual feeling. I can't tell you belong. So belonging is actually different than inclusion. I could say you're all part of Dr. Hers, but maybe there are people in this room that don't feel like they belong just because they're part of something. And that's really important. It is your own personal individual feeling. But we can do some things that to try to make people feel as though they belong, including, for example, using the language of belonging. Now, my daughter actually studies loneliness and social isolation and things. And so we were talking a lot about belonging. And I started to realize, that's when I started to realize that some of the things I was reading in the medical literature weren't consistent or weren't as clear with the psychology and social science literature. And so belonging and social integration is, on one part, and on the other side of things is thwarted belongingness and loneliness. So thwarted belongingness and loneliness. And you'll hear that term thwarted belongingness used a lot actually in the suicide literature. And one of the leading theories behind suicide, the interpersonal theory of suicide, has two components. One is thwarted belongingness, and two is the perception that someone is a burden to others. Those are two. A lot of our trainees, early career folks have suicidal ideation, and suicide is a reason for attrition and from medicine. So I do think that this is something I like to just briefly touch on, but I think the subject of belonging and thwarted belongingness is super important. Again, inclusion is not a synonym. Just because you're included does not mean that you feel like you belong. It's really an important, I've been writing about this, and this is actually, something that we literally just wrote. And what we wrote here, you can read on the screen, but it's thought to be a really important part of attrition and a workplace environment. And so as we think about the issues, keep in mind, when I talked about workforce retention and attrition, those are numbers we can count. We can count how many people left and all that. Now I'm talking about belonging, and this is causality. And causality is thought to be multifactorial. Causality could be you don't pay someone enough. Causality could be discrimination, etc. But now I'm talking about belonging as one causal factor. And in this study that I did, looking at women leaders, those who reported low belongingness, that they didn't have very many belonging factors, were significantly more likely to report their intent to leave the institution. This is a novel study. Why is it novel? If I told you that belonging literature has been around for a really long time, because belonging literature sort of lives by itself, and retention literature sort of lives by itself. And the two haven't really been connected in very many studies looking at belonging and retention together. And so that's actually novel, and it's really important work that we need to be doing. So what can we do right now? First of all, is what I'm talking about today, which is educating people about belongingness and what that means, and really referring back to the social sciences literature and tying it into things that we think about and make sure that we're sort of on the same page with when we talk about belonging. I think it's important to tell people they belong. I really do. Just like I think it's important to tell those we love that we love them, I think it's important to tell those that we want to belong that they do belong. Not that we can make them belong, but I think that the language of belonging is important. Mentoring and sponsorship, really important. I showed you examples of that today. And I mentored the individuals who presented through this experience so that they would be successful, and they were all fabulous. Form and foster group identities. Here's the thing about belonging. This might seem counterintuitive. Belonging is about in-groups. If everyone belongs, there's no belonging. And so in order for there to be in-groups, there also have to be out-groups. Now, that might feel uncomfortable to some of you, but that is actually, when you start to look at the science, that is human nature. We all gravitate to belong. We want to belong to a family unit. We want to belong to different groups. We want to be part of UB. We want to be part of anesthesiology or whatever, social identities, race identities, different identity groups, etc. Those foster belonging. Sometimes in-groups and out-groups can be problematic, no doubt about it. But let's just all understand that groups are a fact of life. They are human nature, and they've been around forever. And it is very unlikely that they will disappear. employ rituals, traditions, or practices. One of the things that I do with one of my mentoring groups is we do this thing called high-low buffalo. And buffaloes actually, so we talk about a high, we go around the room, talk about a high, a low over the past month, and a buffalo's any random thing. And it was so funny today because I got a bracelet with a buffalo and I was like, oh, that's so cool because we talk about buffaloes all the time. And it's like a little ritual. And we were doing that the other day in a group meeting with some people who don't do high-low buffalo, but new high-low. And I said to my mentees, because we didn't have a lot of time, I said, let's just do buffaloes. Let's just do the random thing. And so we went around the room and the other people in the room were like, oh, like, I get it. You can say anything you want. Like literally nothing's off the table. So buffaloes are fun. And I love my buffalo bracelet. All right. Discuss organizational group and individual values and how they align. There needs to be alignment in order for someone to feel as though they belong. No one belongs here more than you. Thank you.
Thank you, Dr. Silver. That was wonderful. I'll have you stay up here because we have time for 1 or 2 questions. I just want to say I was inspired as a private practice owner with a staff of 20. I'm using belonging language. My previous was, I'm so happy to be on a team with you, but now it's going to be, Karen, you belong here. We have time for about 1 or 2 questions if there's anyone who would like to ask one. If not, Nancy Nielsen, raise your hand first. Jen is coming up. And then we'll be doing networking, so there'll be lots of time for questions.
What does Pachacucha mean? And
What?
how do you spell it?
Good question. I don't know the actual definition for Pechacucha. It's P-E-C-H-A, and then Kucha is K-U-C-H-A, and it's used a lot in technology or computer industry exhibitions and things like that, where they have this really fast-paced thing. It's also used in academia a lot. So if you Google Pechacucha, you'll see examples and you'll also see training and so on. And Ashley Alex did that. That's what I told her in part to do. I gave her a little training session, but had her watch some Pechacucha on YouTube.
I Googled it, and it is a Japanese phrase that means chatter or chit-chat.
Japanese phrase that means chatter or chit-chat. There you go. Nice.
This will be our last question, and then we have tons of networking time. Oh, Dr. Brodsky, you'll be our last question.
All right, Dr. Silver, thank you for coming to Buffalo. In addition to all these things that you're doing, I need to also say that you're a champion for long COVID patients. And we've been on the same long COVID collaborative for 4 years. So I'm very excited for you to come here. But my question is, what do you think is the common mistake that women make? And what do you think we should be looking out for to avoid this mistake in our career? Thanks.
That's such a great question. And thank you so much. We spent a lot of nights and, together after hours, et cetera. I think women are just fine the way they are. I really do. I think all of you are just fine the way you are. I don't think that there's like a mistake. I don't think there's a problem with you. I think we can all aspire to do things differently and so on. But I really try not to fix women. I try to fix systems and structural issues. Keep in mind that structural sexism and structural racism, those aren't actual structures, but what they are policies, procedures, cultures that predict a certain outcome. And we can predict a certain outcome when we have policies and cultures and things that are not very supportive. Now, one example I give, actually, and this gets to do we fix the women or do we fix the structure problems? So one example I often give in a talk is queuing at the bathroom. So women stand in line to go to the bathroom. They do. They stand in line a lot. If you ever want to see privilege, it's walking into a men's bathroom. That is like literally privilege. And I don't mean that to be condescending or anything. That is what privilege looks like when you don't have to stand in line at an airport, to go to the bathroom and things. Women biologically take longer because they're menstruating. They often take their kids with them to the bathroom. So behaviorally, they take their older parent to the bathroom, etc. So given that, I was an engineering major, and when I was 18 years old, I was a teenager and I could solve that design problem. That's a throughput issue, right? That is a straightforward throughput issue. So if a teenager can solve that design problem, why do we have an international issue of women standing in line? Women have time poverty. I'm not kidding. There are really simple problems to solve, and we're not solving them. And that has to do with we'd fix the women. Now, if we fix the women, we could stop her from menstruating, right? We could fix the women, or we could fix the structure. There's things we can do. So let's just fix the structures and, celebrate women, and you are all just fine the way you are. Doesn't mean that there's not room to improve your own skills and do things, but you are fine the way you are.
How do you create a sense of belonging in a world where people seem to be isolating themselves more and more? Nobody wants to come to work. They want to work remotely. Nobody wants to come to class. They want to binge on videotape lectures like YouTube before the exam. People don't talk to each other. They text each other rather than turning their head to talk to the person next to them. I'm mystified.
That's such a great point. And it is really true that we have to guard against things that keep us more socially isolated. I mentioned that my daughter's studying loneliness and social isolation. The interesting thing about it is that you don't have to have lots of social connections to perceive that you're not lonely. You can have a couple of close relationships and you can perceive yourself as, fulfilled, and that's great. Or you can have a lot of relationships and perceive yourself to be very lonely. So it is your perception that really matters. Now, there are some things we could do. I'll give you a quick example. Our division chiefs, we had a holiday party, and it was right after the pandemic sort of loosened up and we could have a holiday party. So it was about a year and a couple months ago. And I told the division chiefs, look, you have all these new faculty. Call them on the phone, like have a conversation with them and say, I want you to come to the party. I know it's hard to come to a party when you don't really know people, but I want you to feel like you belong. And if you tap me on the shoulder and tell me you're there, I'm going to introduce you to 3 people that you don't know already. So I'm going to help you network. So I gave them a very specific thing to say, that these people belong, that we want them there, et cetera. And I think that sort of intentionality is really a big deal. I also think when you're on Zoom and things like that if you're having a meeting, that you should encourage as much as you can to have people pay attention. And I like it when people nod along when they're watching Zoom. So I do that. I sit there and I'm like, I'm a good Zoom participant. I will nod along and I will let you know I'm listening and that, that this is important. So thank you very much, everyone.
Thank you so much, Dr. Silver. Thank you to all the volunteers. We have continued conversation and networking outside and food. Please, for those interested in joining the mentoring program, visit our booth. And we have a dessert station by the student leaders. Thank you again. We know we have actionable things for everyone to do. And thanks for joining us tonight and share your ideas for future programming.
I think we will. Issue. I think it's really hard. Right. Yeah. Yeah.
All right, yeah. Great question. Very cool. See you later.
Right. And it's, the budget has driven so many of these things and the value. I mean, if the finances are reflecting the values, that's where, the values, there's no value placed on that. So, if Yeah. Yeah. Right. Yeah. Well, I became really sick when I gave up the job to, senior associate. Yeah.